Hey, Daryl Baskin here, finishing up the San Antonio Ophthalmology course Retina, part 1 of 2 review with our section on posterior segment manifestations of trauma. Evaluation of the patient after ocular trauma is fairly important. You want to determine if the globe is open or closed, determine if an IOFB is present. Essential components of evaluation include a complete history. It's very appropriate to ask what happened and how. A thorough examination without damaging the eye. CT scan without contrast. MRI could be ordered only after ferromagnetic foreign body has been ruled out. Ultrasound could be considered, but you have to avoid expulsion of intraocular content, and it may aid in detection of non-radiopaque IOFBs like plastic or wood. Okay. The book gives you some helpful hints on identifying whether you have an open globe injury or not. Well, severe chemosis, ecchymosis, eyelid edema, low IOP, iris damage or incarceration. Ooh, misspelled that one. Incarceration, and cataract, and my favorite, presence of entrance wound. Presence of nail sticking out of eye. So normal IOP and absence of findings on exam do not rule out an open globe, and if it's suspected but can't be confirmed due to lack of patient cooperation, etc., an EUA exam under anesthesia plus or minus exploration should be performed under general anesthesia. I mean, don't go crazy with this, but if the mechanism it makes you suspicious for an open globe and it's like a 2-year-old and you're not getting a good exam, and you may just need to do an EUA. So, okay, ocular injuries can be broken down pretty easily here. Closed globe, open globe. Closed globe can be a lamellar laceration like a partial thickness or just a contusion. Open globe can be a lacerating injury or a rupture. Think about a grape, the difference between smashing a grape under a foot, that's a rupture, versus cutting it with something that's a laceration. Penetrating means you basically just have one eye wall that's affected, and perforating means you have an entrance and an exit wound, and IOFB means intraocular foreign body. All right, so this is just from a month or two ago. This is from Dr. Hine, who sent me this picture, the patient that we saw together. I didn't have to see them in the middle of the night, thankfully, like he did. Anybody want to guess what this is? Of course, I thought this is lacrimal gland prolapse or orbital fat prolapse, but it turns out this is actually the right eye. This is the nasal side or medial side, and this is the lens underneath the conjunctiva, which I haven't seen before. And the fellow eye also had a lens, but fortunately it was still inside the eye. Thankfully, we were able to get this patient did a primary repair on the first eye. On the second eye, because of her homeless situation and lack of access to care, we went ahead and set her up with a Acreos IOL and got this lens out, this crystalline lens that was doing her no good, out of her eye, thanks to our awesome retina fellow there. Okay, so what's the diagnosis here? We see some retinal whitening. Old name was Berlin edema. It's called commotio retinae. So the blunt trauma leads to shock waves that damage the outer retina and RPE. Sheen-like retinal whitening. Vision can be reduced. Gradual recovery may occur if they don't have other complications. Usually, if they don't get pigmentation, they do okay. All right, what's our diagnosis here? This is an 11-year-old hit by a tennis ball. I think her brother hit her while they were playing tennis. Visual acuity is 20/25. So, anybody? It's a choroidal rupture. You see the disruption of the RPE, hyperreflectivity within the choriocapillaris choroidum and sclera there. Blood trauma leads to ocular compression, causing tears in Bruch's membrane and RPE, which are relatively inelastic. Adjacent subretinal hemorrhage is very common. You can see that next to her nerve. Ruptures may be single or multiple, usually concentric to the disc. This is her a couple months later. Now her vision is 2200, and she has a subfoveal hemorrhage. What are we thinking? C&V. And yeah, there you see it on FA, you see it there on OCT, and 2 months after that, she got one bevacizumab. I should have mentioned that. She's back to 20/25 plus, but clearly not her best vision. So, sad case. 23-year-old male, status post flying door handle. I'm putting that in air quotes. I didn't see this patient, to the left eye. Visions, count fingers at 2 feet. Anybody want to guess mentally what this is? I'll show you an OCT now. So, post-traumatic macular hole. What mechanisms can lead, could blunt trauma, what mechanisms could blunt trauma, by what mechanisms could blunt trauma lead to a macular hole? Book says contusion, necrosis, and vitreous traction. And 10 days later, without surgery, the patient was 2200. Obviously not a great outcome, but the hole is closed. Okay, what's our diagnosis here? We have extensive subretinal fibrosis, going from basically the fovea on out. You can see some concentric rings right here, so choroidal rupture, I think we could say safely right there, but this is more than just choroidal rupture. This is 3 months prior, same patient. Patient had been shot, he's 17-year-old, with a bullet to the right orbit. And here you see subretinal hemorrhage, just extensive disorganization of the retina there. So retinitis sclerotiria caused by high-speed missile injuries, also paintball injuries to the eyelids, choroidal retinal rupture, necrosis, extensive subretinal hemorrhage, interretinal hemorrhage, extensive scarring ensues. Secondary RD almost never occurs, so that's good. Scleral ruptures. Where are the two most common sites for ruptures? Think about that for a moment. One is the corneal limbus, especially through previous surgical wounds, and then the other is under rectus muscle insertions where the sclera is the thinnest. Diagnosis. This is a retained IOP. This is bone. 18-year-old sustained an elbow to the eye while playing basketball. So pushed a bone into his eyeball. Vision is 20/20. So if you have a retained IOFB, the reaction of the eye depends on what the chemical composition, sterility, location of the IOFB are. Well-tolerated stone, sand, glass, porcelain, PC IOLs that are made out of plastic, cilia even. Not well-tolerated zinc, aluminum, iron, copper. This is a patient. We thought maybe he had bone in his eye, but it actually was a metal casing or brass casing of a brass bullet casing. He'd gotten shot, but just the mechanism didn't make sense for the bullet to be in the eye, but it was. That was a couple months ago. So pure copper, like copper wire, is really bad. It causes acute calcosis, if you want to say it that way, and severe inflammation. If you have less than 85% copper, like brass or bronze, it causes more of a chronic calcosis. So calcosis can lead to decimated membrane deposits like Kaiser-Fleischer rings. This is that brass bullet casing, and we're pulling it out. Greenish aqueous particles, green discoloration of the iris. His iris looks a little green right there. Sunflower cataract, he had no lens. Brownish red vitreous opacities, and didn't see that. Metallic flecks on the retinal vessels and eye limb, didn't see that. Actually, I did see some brownish stuff on his optic nerve. I assume that was like PBR pigment. Anyway, siderosis bulbi, that's related to iron, primarily deposited in neuroepithelial tissues, promotes this thing called the Fenton reaction. Photoreceptors and RPE cells are very susceptible to damage from iron. Nyctalopia, constricted visual field, poor visual acuity, rust-colored corneal stromal staining, iris heterochromia, brown deposits on the lens, and then cataract. Vitreous opacities, peripheral retinal pigmentation. And post-traumatic endophthalmitis occurs after 2 to 7% of penetrating injuries. Incidence is higher with IOFBs, and that's a no-brainer. Rural settings, lens capsule violation, and we recommend using fourth generation fluoroquinolones or third levofloxacin. I never know if it's third or fourth. I give Moxie 400 for like 10 days, and then also intravitreal antibiotics, of course. And then if we can do a vitrectomy, we will. But if the cornea looks like that, we don't. Bacillus cereus accounts for 25% of cases. Okay, what's your diagnosis here? Yeah. So this is abusive head trauma. Severe shaking of infants leads to this clinical picture. Presenting sign of child abuse is AHT about 5% of the time. So you may be the person who makes the diagnosis, and then you have to report to a government agency. Signs include retinal hemorrhages, cotton wool spots, retinal folds, these hemorrhagic schisis cavities, pigmentary maculopathy later on. And finally, we're going to end with this patient, 53-year-old male, no recent complaints, referred by general ophthalmology to the retina clinic when I was a fellow. 20/40 vision, both eyes. History of bipolar. Anybody want to make a diagnosis here? Here we go. We see focal loss of outer retina. I asked this patient 2 questions. Did he ever smoke I'm not going to remember it now. Peyote, is that the name of the thing they used to smoke? And then he said no. And then I said, have you ever stared at the sun? He goes, oh, yes, I have, actually. So anyway, he said he used to stare at the sun when he picked cotton, although we were in Philadelphia, so I'm not sure where he was picking cotton. So that's the story on him, solar retinopathy. This is a patient of mine from my Air Force days with the pattern dystrophy, but a really interesting volcano-type picture on his OCT, like a little smoke and volcano. Anyway, so I just want to say, this is I think this is either Kinyarwanda or Kirundi. It's probably Kinyarwanda. And Motsi Wikirunga, which means, I think, smoke from the volcano. Anyway, so thank you very much. Appreciate your time. This is the end. This is my family last year. We had a new baby in 2024. Pretty excited. I look old enough to be his granddad, but I'm fine with that. And we're getting ready to move to Alaska this summer. Pretty excited. And again, always remember to wear your eye protection. Thanks, everybody. Bye for now.